Welcome to today's webinar in the Knowledge Mile series, part of the Lord Mayor's lectures on behalf of Professor Michael Marnelli, whose theme for his mayoral year is Connect to Prosper. In this free online lecture series, we address the connections in and around the square mile, which Michael likes to call the world's coffee house, and how these might help us to tackle future global challenges. I'm Professor Tim Connell, Chairman of the Gresham Society, a Fellow of Gresham College here in the City of London, and also sit on the Court of the Stationers' Company. I'll be convening this session and moderating the questions and answers after today's lectures. So this is a plan today very quickly, rapid introduction from me, then handing over to Professor Chris Hammond, and we'll then have 20 minutes for questions. Today we have a really interesting topic, Seeing is Believing, the Miracle of Modern Eye Health Care. So I'm delighted to welcome Professor Chris Hammond today, who is the Frost Professor of Ophthalmology at King's College London, and is also consultant at Guy's and Thomas's, and as you may imagine, a member of the Worshipful company of spectacle makers. So Chris, can you tell us something more about yourself?
Sure. Thanks very much for inviting me. I'm Chris Hammond. I'm the Professor of Ophthalmology at King's College London, and I'm a consultant ophthalmologist, so I'm an eye surgeon and looking after particularly pediatric ophthalmology and strabismus, but also cataract surgery. I qualified at medical school, Oxford and Cambridge, did most of my training in London, and I've been here for the last 15 years as professor.
Goodness. Now, can you tell us more about modern eye health care and quite why you believe it to be such a miracle?
Yes, indeed, I will. Would you like me to share my screen?
Oh, yes, please.
All right, we will try and do that. And great. Hopefully you can all see that. So, as Tim has just said, the Lord Mayor's theme of this year is Connect to Prosper. And he is very keen, as we've stated here, to develop the City of London and the Golden Triangle as a global innovation networking centre for the life sciences sector. And we had a colloquy on the 4th of June, and we're moving towards trying to tackle some of the issues at our next meeting in September and come up with an action plan. There's been some amazing research in London over the last few decades in terms of vision and sight and trying to prevent blindness and allow vision for all. One of the things we've been doing for many years is taking photographs of the retina. The top left image you can see is a normal eye, and the pictures along the top are patients with firstly wet and then with what's called dry age-related macular degeneration, which is the commonest cause of poor vision in this country. And the bottom left images are optic nerves showing various degrees of loss of this pink color here, which is the neuroretinal rim, the nerve layer, which is a disease called glaucoma. But one of the real sort of jewels in the UK's crown is that many years ago now, they instituted a national screening program for diabetes, photographing every diabetic's eye once a year and to detect disease before it caused vision loss. And there's really good evidence now that blindness due to diabetes has fallen. It used to be the commonest cause of poor vision in working age population. It is no longer. And this is held up around the world as a real model of care, where in a sense, what we call telemedicine, pictures taken by professionals in eye screening services, and they are graded and read centrally. And there are now AI models of reading these images. And indeed, AI, artificial intelligence, has really been a big thing in eye research. And this paper was published on mainly UK data sets. But what they did is from a simple photograph of your eye, the top left image of a normal eye, nowadays they can predict your age, your sex, whether you smoke or not, whether you're diabetic, just from that one single picture. And that really opens up the door to the future of us being able to establish good health and ill health and potentially predict problems before they happen and hopefully therefore prevent them. And this is just from one simple retinal photograph. We can do this. This work was done in association with Google Mind and a collaboration with Moorfields Eye Hospital. Most of you, if you've been near your optician recently, will have come across a newer scanning that we've been using in hospital service for some years now called OCT, or optical coherence tomography scanning. And this is in effect an optical cross-section of the retina that does the seeing at the back of your eye. And if you look at this picture, the top colored image is of a histology slide. So someone who has died, their retina, which is stained with various colors to look at the different layers of the retina. And the bottom picture is one of these OCT scans. And you can see that we really see human anatomy writ large in life in a live patient. And so we can really establish where there's a problem in the retina, what layer, and institute treatment. And it's transformed our management of many eye diseases, including diabetes. And the images on the right are scans of the optic nerve, which again is damaged in glaucoma. And again, we are able now to get incredible depth of data from your optician to manage the patients with glaucoma and other eye conditions. And what's more than that, a team at UCL and Moorfields Eye Hospital have recently published an amazing paper where they've used OCT scans and also retinal photographs and with artificial intelligence, they can predict future heart attacks, future strokes, even Parkinson's disease from these images. Now, at the moment, it's not quite at diagnostic level, but essentially they can, up to 7 years before, predict who is more likely, for example, to develop Parkinson's disease. And therefore, again, in the future, we may be able to use this information to really mark who might be eligible for treatment or intervention to try and improve their long-term prognosis and health. So from simple eye images, AI is really rendering us able to look into the whole system, into systemic diseases as well. Another eye first in London was the first gene therapy for any disease, and in particular, the gene therapy called Luxturna was licensed for use in the NHS in 2019. And what gene therapy involves is for patients who have a mutation in a gene which damages their retina and therefore makes them blind, by introducing a healthy gene into a virus, a vector, which is then injected underneath the retina in the eye, we can restore function to a retina that was not working. And Luxturna is now being used across the world for these patients with blinding eye disease called retinitis pigmentosa, and in fact, in this particular one, Leber's congenital amaurosis is the name of the disease. And now in London, at the Evelina Children's Hospital here at St Thomas's Hospital, and also with help from surgeons from Great Ormond Street, we are now doing gene therapy for another disease, AIPL1 gene mutations. And for children like Khadija here, that the results are pretty amazing. Children who were blind can now navigate and see the world that they didn't see before. These gene therapies are extremely expensive. It's going to be quite a challenge in the long term as they proliferate. But for those rare people with these mutations, they are life-changing. For common diseases too, eye care is really improving lives. We now inject people's eyes with wet macular degeneration. And as you can see on the graph on the right, the number of injections is going up year by year in the NHS and the UK here. But the studies now globally show that there is already 20% less blindness due to these treatments than before. And it's not just the treatments that's getting better, but also smoking going down. And smoking is one of the major risk factors for late age-related vision loss. So it's again another success story. However, of course, as our population ages, age-related diseases are more common, and therefore there's an increasing burden on health services throughout the world. But for the rest of my talk, I'm going to concentrate on cataract, age-related cataract. That is where the lens of your eye goes cloudy and you can't see well. So it causes blurred vision or difficulty seeing, and also quite commonly problems with glare and dazzle in bright light. And here's a photograph of someone with a cataract in their left eye. Now this cataract is very dense. You can see the white cataract in their pupil compared to the clear right eye. Nowadays, luckily, people don't have to wait until they're completely blind to benefit from cataract surgery. But this is a subject that I want to talk about. The reason is, firstly, that it's the most common operation performed in the UK. Last year, there were 600,000 operations performed for cataract surgery. You can see here a slightly increasing trend over the years, apart from the dip due to COVID. But in fact, in the last year, the number went up significantly from 450,000 a year to 600,000. That's partly due to backlogs, but also due to a proliferation of private providers working with the NHS to reduce waiting times as well. Coincident with that, there's an increase in the spending on cataract. Here you see 2022 to 3, the NHS spent about £1.25 billion on eye services, and something like not far off a third of that was spent on cataract surgery. So if we could reduce the amount of cataract surgery we did by reducing the number of people who developed cataract, for example, we could certainly save significant amounts of money. The other reason to talk about age-related cataract is that it's still the most common single cause of blindness in the world. Most recent figures, around 30% of blindness in the world is due to cataract, which is pretty depressing when there's a very successful operation to fix it. The problem is that this is primarily in sub-Saharan Africa, where there are very few facilities and even fewer surgeons to do the surgery that is needed. Finally, and the main reason to talk about it in this year, is that we're approaching the 75th anniversary of the world's first intraocular lens implant at the time of cataract surgery. And it was implanted by someone called Harold Ridley, who I'll discuss again in a moment. Because the problem is, if you take the lens of the eye, which does the focusing, the cataract, out of the eye, without a new lens, then you can't focus and you're effectively still blind. So what used to happen, and still does in some parts of the world, after cataract surgery, patients have to wear these thick pebble glasses to try and see, which, although you can see well, they have a very poor field of vision because of distortions around the edge of their vision. And so Harold Ridley had the idea of developing a lens to put inside the eye. So he was based at St Thomas's Hospital here in London, and what he noted was that during the Second World War, when he was treating pilots who had injuries from the perspex screen in front of the pilot, he noticed that the eyes didn't react to that perspex in the eye. So he had the idea of putting in a perspex lens into your eye so that the patient could focus again. And so he did this. As I said, the patient had his cataract surgery, in fact, in 75 years ago in 1949, and he had the lens put in subsequently. And Rayner, a lens making company, made the lens for him. And indeed, Rayner are still making lenses we use in cataract surgery based on the south coast of England still today. And there were a lot of technical problems with these lenses to start with. They didn't really understand the mechanics and how these lenses could damage the eye. So really, they were only used widely in the 1980s in the UK, and of course are extensively used around the world. Many million people have had cataract surgery with lens implants, thanks to Harold Ridley's pioneering work. So, sorry, spoiler alert. Here comes a short video of 20 seconds. So if you're squeamish, look away for 20 seconds. But this is a video of Harold Ridley taking out a cataract and putting a new lens in. In those days, no microscopes were used for the surgery. It was just with the naked eye. But what you can see here, and here come the 20 seconds, is taking out the white cataract from this patient's eye in complete the whole lens, and then inserting this perspex lens into the eye. The patient's under local anesthetic, so just cocaine in those days to numb the eye. And then once the lens is in the eye, they put what we now regard as rather rope-like stitches to close the very large wound they've had to make to get that piece of perspex into the eye. Modern surgery, the lens implant is tiny, as you can see here in this illustration. It's got these two little feet on it to keep it in the right place in the center of the eye. And we can fold it. It's made of acrylic, and we can post it into the eye. So modern cataract surgery involves an incision of about 2.2 millimeters in diameter. We can use a machine called phaco emulsification using sound waves to break up the lens into tiny pieces. And then we can post this lens into the eye through an inserter, where it unfolds into the capsule or the bag where your old lens used to sit, which keeps the lens in place. And then the incision doesn't need any sutures at all, any stitches at all these days, because of making everything so tiny. So pretty different to the Harold Ridley operation 1950, but fundamentally a major work by him. Now, what causes cataract? How might we minimize our chance of getting a cataract? I've been working with the Twins UK cohort for over 20 years now. They're based at St Thomas's Hospital. It's a very large study of 16,000 twins from all across the United Kingdom. And twins help us separate out nature from nurture. Identical twins similarly share the same genes and share similar environments as children. Non-identical twins only share half the genes. And we can use what we call the twin model to try and work out how much of a trait is due to genetic factors and how much of it is due to environmental factors. And so over 20 years ago, I published this study looking at 1,000 twins where we very accurately measured cataract. The bottom images you can see on the left is a twin with a fairly clear lens, what's called the nucleus, the central part of the lens that I'm highlighting here. And the twin on the right, you can see this white haze here has got some nuclear cataract here. And when we did the maths, we showed that actually almost 50% of the variability why someone may get a cataract at age 65 and someone else may get a cataract at the age of 90 is due to genetic factors. However, 38% of the variation was, as you might expect, age, but also some of the variation was due to environmental factors as well. And when we look at those environmental factors, they're kind of summarized in the circle here. And we can see the top, that fruit is good for cataracts. And indeed, we did a twin study showing that higher vitamin C intake was related to people having a slower progression of cataract as they get older. Leafy green vegetables in particular contain lots of antioxidants, which have been shown to reduce the risk of developing cataract. On the right, smoking, as well as a risk factor, as I mentioned earlier, for age-related macular degeneration. Smoking is a significant risk factor for cataract as well. I mentioned genetics, the DNA on the bottom right of our illustration here, and I and others have done some genetic studies. We found a bunch of genes that are associated with age-related cataract, and while at the moment they don't make any particular difference to how we might look after people with cataract, again, in the future we hope they may lead to development of potential new treatments or preventive measures to stop cataract forming. Sunlight, ultraviolet light is also associated with certain types of cataract. People who spend more time outdoors, particularly working in hot, sunny climates, hotter and sunnier than ours, are more likely to get cataract. We recently, with researchers from Moorfields and UCL, working on the amazing UK Biobank project, looked at pollution, and we found that pollution is a risk factor for developing cataract. And really, increasingly over the recent last few years, it's become apparent that pollution plays a significant role in a lot of age-related diseases. And so the measures that our mayor, as opposed to our Lord Mayor, has done in terms of reducing pollution in London can only be good for eye disease. Diabetes on the left is a significant risk factor for cataract, and as most of you will be aware, obesity is a significant risk factor for diabetes. So clearly, again, diet and exercise, trying to reduce the impact of the obesity epidemic will be good for eye disease also. Finally, there are some medicines like steroids that predispose people to be more likely to have cataract. Sadly, not much we can do about those. If you need the medication, you need the medication. Luckily, cataract surgery is very effective. So to conclude, I hope I've shown you a little bit about some of the amazing things that are happening in vision at the moment in terms of research and also influencing people's lives. There are challenges, however. The aging population is presenting a problem to all developed and indeed now the less developed countries in terms of impacts on healthcare services. There are more treatments available for more people, but that just obviously adds to the burden on our health services. Novel treatments like gene therapies are very expensive. Relatively few people benefit from them. They cost an awful lot to develop. We need to think about models of funding, how we might pay for these expensive treatments. There's a gene therapy for a spinal disease, for example, that costs £1 million per treatment. Reducing inequalities is important in our society, and we need again to work to make life chances equitable for the population. So I'm going to conclude with the purpose of the Worshipful Company of Spectacle Makers, which is better vision for all. I'm very grateful to my master, Elizabeth Schilling, who you see with her large medal on the photograph here. She made me a liveryman last year, and I'm proud to be a liveryman of the Worshipful Company of Spectacle Makers. Thank you all for your attention, and thank you for the invitation.
Well, Chris, that was absolutely incredible. I must admit, when I first saw your title as The Miracle of Modern Eye Healthcare, I thought to myself, gosh, what miracles. I'm absolutely bowled over by some of the things which you've mentioned. And I must admit, being in the higher quartile of the population, I feel quite reassured that every time I see an optician in the high street, there's an awful lot going on behind those windows. I have to start off from the little video. A personal question: what drew you into this particular aspect of medicine, and what kind of training did you need to have before you were able to operate?
Good question. Yeah. So, one of the joys of eyes ophthalmology is that not only are we a surgical specialty, so we cure people's problems, like take out the cataract to make them see better, but we also have a lot of long-term diseases like this condition I call glaucoma. So we get to know some of our patients very well, but others we are in and out, they're sorted and they don't have to come back to see us. That's one attraction. Also, almost every disease affects the eye in some way, so it's very interesting that we see our pathology and we can link to so many other specialists in different fields of medicine, particularly neurology. The brain and the eye obviously work very closely together. We generally get a reasonably good night's sleep when we're as eye surgeons, which is also helpful. That must be said. In terms of training, Nowadays, training is a 7-year program in the UK from start to finish to being graduating as a fully fledged trained ophthalmic surgeon. So as well as the medical school and 3 years of foundation training, or 2 to 3 years, junior doctors now do a 7-year training program. And essentially nowadays, which of course didn't happen in my day, I'm similarly in a certain demographic to you, but nowadays there are amazing simulation devices. So there are some computer simulators that simulate surgery, so people can learn the hand-eye coordination needed before they start operating on patients. And then what happens is we generally do most of the operation, and they do the easiest bit at the end. When they can do that well, they take one step back and they do the last 2 steps of the cataract operation, and so on until they're doing the whole operation. So we gradually increase their exposure as they acquire the skills. But nowadays you can't go near a real life human being without having had simulation, and we even do cadaver training for eye muscle surgery, for example, and eyelid surgery. So there's a whole bunch of training goes on before patients are exposed to trainees, and obviously every trainee has a consultant watching with them when they're doing surgery. Sadly, my day, it was kind of the old adage of see one, do one, and teach one, which is not as good as it is now.
Right. Now that's really quite incredible. Well, now the questions are coming in. All sorts of interesting items here. Jenny Tracy asking, when will gene therapy be available as a routine treatment for blindness?
Good question, and the answer is no time soon. The difficulty of gene therapy is that each therapy is specific to one particular gene, and so there are, of course, many thousands of genetic mutations in eye disease, let alone every other disease, and each gene therapy has to be custom made for that problem, and therefore it's a real challenge for us. And you may have read in the press recently that, for example, Great Ormond Street are trying to develop a gene therapy within the NHS, trying to reduce the enormous costs that gene therapies are to develop. The regulatory approvals are legion and take many years to navigate, partly because you're inserting new DNA into someone's cells. You've got to be pretty careful it's not going to cause tumors, and pretty careful that it's safe and not going to have unwanted effects. But the problem with that is that then the companies have to charge vast amounts of money to recoup the amount of money it costs to develop those gene therapies. So we need to think of new models of funding, and it's something that the Lord Mayor's colloquy group, which the Worshipful company of spectacle makers, we're very privileged to have been invited to join that, are addressing is how can we find new models of funding for these very expensive treatments. There is work on gene therapy for some of the more common diseases. At the moment, nothing yet in the pipeline, in trial. But again, that will be happening for the more common diseases, and we again hold some hope that we may be able to, for people with blinding diseases, alleviate their problems.
Gosh. Simon West, common topic, I would imagine. Do you recommend laser eye surgery for vision correction?
So laser eye surgery for vision correction, which is largely done outside of the NHS, it is for the most part very effective, and 98% of patients are entirely satisfied with it. It's pretty good for short sight, not bad for astigmatism and other reasons people wear glasses, not quite as good for long-sightedness. Like any operation, it's an operation, it carries some risks, and so it's clearly a personal decision as to whether the benefit of not having to wear glasses or contact lenses outweighs the risk of having an operation. So on the whole, most people are very happy with laser. The difficulty at the moment is for those of us beyond middle age, needing to see well in the distance and for reading at the same time. Laser eye surgery does very well to give you lovely distance vision, but you still have to put a pair of reading glasses on. Sometimes people go for one eye near, one eye distance. True what we call presbyopia correction, enabling you to see near, middle, and far distance after laser, is still really not there yet. So it's laser particularly effective for the younger age groups. But there are some older people who are very happy. But essentially, if you're getting to the age where you're going to need cataract surgery, that's a better way of correcting your vision than having laser surgery.
Very interesting. Now, I noticed the spectacle makers were founded in 1629, so a historical question's inevitable. Devi Maserati points out that Casanova wrote about lens implants, but saying they weren't successful because glass lenses at the time were rejected. Does this kind of operation go back that far?
Not to my knowledge. The yeah, good question. Not to my knowledge, no. The first cataract surgery, obviously, they used to do what's called couching, pushing the lens into the back of the eye to try and push the cataract out the way, which gave people very blurry but vision for a few years before they did go blind from the complications. But and then taking out lenses really started happening in the 16th, 17th centuries. But lens implants, to my knowledge, Casanova wasn't putting them in, but I stand to be corrected as not as a historian.
Oh, that's an interesting one. Now, Michael Drury, coming back to the modern day, he's read contradictory opinions about the use of sunglasses. What do you think about the use of sunglasses?
So I think sunglasses are a good idea in the sense of, firstly, ultraviolet light is not good for our skin, and so, for example, skin cancers around the eyelids in countries like Australia are a big problem. Clearly, we get less sun in our country, and so you don't have to wear sunglasses when you're kind of outdoors if it's not particularly sunny in this country. But clearly, in full sunshine, as a general, it is recommended. It's short-term exposure is not going to do much harm, but if you spend a lot of time outdoors, it is recommended, reducing your chance of getting cataract, for example, and reducing your chance of getting skin cancer. But as I say, it's not a major issue in the UK in particular.
But Polaroids would be better than
Yes,
sunglasses.
so yes, as you say, you want to get good protection against ultraviolet, so Polaroid, but some of the modern filters that are in not the £2.99 sunglasses you might buy online, that some of the filters are very good at filtering out all the UV light as well as Polaroids.
Abel Arbour, again, a personal experience, has recently had eye surgery, and I will quote, "I can't thank you and others enough for this brilliant work and practice." But his question is, why should younger people, those under 50, be experiencing cataract? Just wondered whether there's an element
Yes.
here across the
So
board.
most, as you say, most cataract is age related. We see so a couple of issues. One of which is children. Some children are born with cataract or develop cataract at a very young age. They usually have a genetic problem. They usually have a mutation in a gene that causes the lens not to form properly or not to be crystal clear. So we do something like 250 cataract operations a year in babies in the UK. So it's not common, obviously. Many of the younger patients of under 50 have had other eye problems. They've either needed some forms of eye surgery, or they've got inflammation in their eyes, a thing called uveitis, or they have other medical problems. They've needed a lot of steroids, or they've had very, very poorly controlled diabetes that might have led them to have a cataract much younger than average. But as you say, the age-related ones are predominantly going up. But as I say, a significant proportion, 10% of surgeries in people under the age of 65, but clearly they're more on the 60 to 65 than the 50 to 55 age group.
As a practitioner, I must ask you, what's it like operating on babies?
Challenging, and obviously they're fast asleep for the surgery, unlike most cataract surgery, which is done under a local. But it is different and it is challenging, and the outcomes are much more complex because the children haven't yet developed normal vision, and therefore, and even though in kids over the age of 2, we do put an intraocular lens into their eye now. We do put an artificial lens in the eye. The young ones, it's too difficult. The eyes are too small, and there are lots of complications. So we tend not to put it in the very little babies, the lens implant. But children having after cataract surgery at that young an age, they very rarely have completely normal vision, unfortunately. But clearly, the alternative is no vision. So we do make a significant impact on these children, but most commonly genetic causes.
Goodness. And of course, the question arises, you mentioned the cost of things. People saying that they might have to wait up to a year for eye surgery on the National Health. Is there any prospect that the waiting list's common topic at the
Well,
moment?
funnily enough, as I mentioned, the huge numbers that of cataract surgeries that are currently being done, the waiting list for cataract surgery across the UK is falling quite dramatically, actually. There's even a slight concern that maybe too many operations are starting to get done, in the sense some of the private providers are doing kind of people who really have very little cataract and really don't have a lot of symptoms yet, and therefore, of course, running the risk of the benefits no longer outweighing the risks of surgery. So, that luckily it is one of the areas, because it's so easy to set up a standalone surgical unit just doing one operation, cataract surgery, and being very efficient about it. There are a lot of providers who've set up services, and so that in fact cataract itself is one of the lesser waiting problems with the NHS now. Sadly, there are longer waits for other operations because it might be argued some of the resources of the NHS are being taken to do cataract surgery and not the other types of intervention.
Gosh, yes, of course. Going back to my dear old grandpa who had cataracts done in 1961, I think he had to wait until it was bad enough before they could actually operate. Do I remember rightly?
You do indeed. We used to say they need to be ripe before surgery, and that's because essentially the operation wasn't as good, and therefore you know if you're half blind from cataract, then you can only benefit from an operation. Whereas nowadays, all right, my vision's just not quite good enough for driving. All right, we'll take out your cataract then, and so and with the modern lenses and the modern technology, the outcomes are so much better that we don't have to wait for someone to be half blind. However, of course, because again it is an operation and does carry some risks, it's important obviously that we only operate when someone has symptoms enough to warrant that risk of the operation. So just kind of taking out a bit of cataract because it's there, if the patient hasn't noticed it yet, then we shouldn't be intervening.
Right. Now, here's a technical one for you. From Margaret Lawrence, can you please describe how an iris clip lens implant works when the lens capsule is absent?
Yes. So for few people, either at the time of a cataract operation, what's called the capsule, where which holds the artificial lens has been broken, or for a few people who've had it removed for other reasons or have had injuries to the eye, we can actually clip a lens onto the iris, the colored part of the eye. So these type of lenses tend to sit in the front part of the eye rather than behind the iris, the colored part of the eye, and we essentially they have a little hook on them, and we hook it onto the iris so that it sits over the pupil and focuses light. So again, not quite as simple and straightforward as the normal lens implants that we use nowadays, but for those few people who need these special lenses, they can be very helpful, enable them to see well after cataract surgery.
Going back to bright sunlight from Richard Cordell, how good are UV filters in contact lenses?
Slightly depends on the lens manufacturer and the lens type, but they are, I think, reasonable. Again, we would recommend if you're, spending hours in bright sunshine to be wearing sunglasses, but for day to day, they're reasonable. In fact, the cornea of your lens, of your eye, and the lens of the eye filter out all the ultraviolet light so that none of it effectively reaches the retina at the back of the eye. So in fact, our eye has its own mechanisms to filter out UV light. So you don't particularly need UV filters in contact lenses or even spectacles, although they often do include them.
Right. I'm taking a look at the clock because I'm afraid we're running out of time now for um, questions. And can we just have a quick look at the forthcoming lectures which are coming up? Yes, Wednesday, 26th of June, Maths for All. Thursday, 27th of June, The Waste of Space. The Problem with Space Debris is an interesting one. And Wednesday, the 3rd of July, Autism Approaches, Enhancing Skills with Virtual Reality and Motion Tracking Haptic Gloves. Well, having gone from modern miracles with ophthalmology, I think we've got something quite remarkable coming up there. So finally, thanks to all the audience for your interest and for supporting the Lord Mayor's lectures. May I say, if you're interested in ophthalmology, you could go onto the Gresham College website and look for the lectures by my fellow professor Will Ailiff, who was professor of physics for a number of years and covered everything from the history of ophthalmology through to the very latest developments. And of course, thank you to Professor Chris Hammond. We're very grateful for these insights, and I think very much encouraged to hear quite how much development is going on in all these areas, and something which in the fullness of time is likely to affect us all. Could I also say that when I rang, got in touch with Chris yesterday, and this morning he rang to say that he couldn't reply to me last night because he's in the operating theatre. I have to say that's one of the best excuses I've ever heard for not answering one of my phone calls. But it does demonstrate the importance of a lecture like this, because we have someone who is very much in the forefront of research and very much of a practitioner as well, which I think is really very, very valuable. So, Chris, thank you very much indeed. If you want to see this lecture or any of the others in this series, you can go on our YouTube channel, and we hope to see you again for another lecture in the Knowledge Mile series. And please don't let's forget the Lord Mayor's theme for the year, which is Connect to Prosper. Thank you very much, and goodbye, everybody. And thank you again, Chris.